Well, good afternoon, everyone. I think most people are now admitted. Welcome to this second in the recent series of seminars, lunchtime seminars, under the auspices of TAPAS, Tackling Air Pollution at School. I'm Paul Linden. I'm the PI on this project. As you know, TAPAS is about bringing together people from all sorts of disciplines to look at the issues to do with air quality in schools, and in particular aspects of the impact of external air quality on internal air quality and vice versa. And also we are very interested in health effects, which is relevant for our speaker today. Before I introduce her, let me just make a couple of housekeeping announcements. As I noticed you all have, thank you for keeping yourselves on mute and with your cameras off while the presentation is taking place. We are recording this, so you'll be able to watch it again at your leisure. And also, please, would you put questions in the chat, and I will moderate those at the end of the presentation. So with that, why don't we start? Let me introduce Pia. Pia is an associate professor of epidemiology at University College London in the Great Ormond Street Institute of Public Health. She works using large comprehensive administrative health databases for children's public health research. Her research focuses on the epidemiology of respiratory infections in children, and she's the PI of the PICNIC study, which sounds like it might be fun. And I think she's going to talk a bit about PICNIC in her talk today. So I'm going to hand over now to Pia. Thank you very much.
Great, thank you so much, Paul, for that introduction, and thank you so much for inviting me to talk to you today. I will primarily be talking about the PICNIC study and how we are trying to integrate data on ambient air pollution and housing quality with national health data for children. So as Paul said, most of my research is looking at the epidemiology of respiratory infections in children. And these are infections like bronchiolitis, bronchitis, and croup, and they tend to be caused by viruses, including now SARS-CoV-2. But most of these viruses we don't have, well, many of the viruses we don't have effective vaccines for. And these infections are the most common cause of death in children worldwide, and in the United Kingdom and many other countries across the world, they are the most common reason for hospital admission in young children, so children under 5. I should say that in the last, during the pandemic, these admissions have dropped significantly, but we are seeing an uptick in them again as schools have reopened and MPIs have been removed and people are starting to mix again. Now, one really striking feature of respiratory tract infections, and particularly more severe symptoms of respiratory tract infections that require hospital admission, is that if you are a child who growing up in a poor family, you are much more likely to be admitted to hospital than if you're growing up in a wealthy family. So this slide of my former PhD student and my colleague Kate allowed me to steal from her, and this shows you risk ratios, also rate ratios of bronchiolitis admissions in children in England, and these are in infants, so that's children under 1 year, and it's rate ratios for hospital admissions for bronchiolitis. Bronchiolitis, 80% of bronchiolitis cases are caused by respiratory syncytial virus. And pre-pandemic bronchiolitis used to account for 35 to 40,000 admissions, primarily in infants in England alone, to an estimated cost to the NHS of about £82 million. So it's an absolutely huge public health problem in infants. And across the year prior to the pandemic, about 15% of all admissions in infants were due to bronchiolitis. So it was a huge, and it's coming back now after pandemic lockdown. So what this graph, Kate's graph, shows is that if you live in the least deprived 20% of areas in England, and versus the 20%, sorry, I should rephrase that. If you live in the 20% most deprived areas of England, your risk of being admitted to hospital with bronchiolitis is 50% higher than if you live in the least 20%, least deprived 20% of areas. So this is so basically, if you're growing up in a poorer area, you're far more likely to be admitted to a hospital than if you live in a richer area. And similarly, this is a study I did a few years back looking at hospital admissions for the laboratory confirmed influenza in children in Scotland. And these are population attributable fractions in this table. And so what this shows is that for children aged less than 6 months, so there are no flu vaccines that are licensed for this age group. The maternal age at first birth, because it's adjusted for parity, so young maternal age at first birth is very strongly associated with low income, lower socioeconomic status. So we showed that if all babies had mothers who were in the sort of who were aged 30 to 39 rather than younger than that, you could prevent 20% of confirmed influenza admissions in these very young children. And similarly, this is a similar study that we did looking at respiratory syncytial virus, or mainly bronchiolitis admissions in Scottish children. And here, the lowest risk group were children who had mothers who were aged 40 years and above. Again, older maternal age at first birth, very strongly associated with wealthier, sort of wealthier women. And then if all children had mothers who were aged similar risk to with children born to mothers who were aged 40 and above, then we could prevent 31% of RSV, confirmed RSV admissions. So we thought that this was a very, very strong indicator that socioeconomic status can explain a large proportion of all the hospital admissions for flu and RSV in children. So I wanted to know then, why is it that children from poorer families are more likely to be admitted for these very common infections? And so I was very lucky to get an MRC grant for the study called PICNIC, which stands for Air Pollution, Housing and Respiratory Infections in Children, a National Birth Cohort study. So we have in PICNIC, we're particularly focusing on the contribution of ambient air pollution and adverse housing conditions like overcrowding or indoor air pollution during pregnancy and before the age of 5 years, and how the contribution of air pollution and housing conditions to the risk of being admitted to hospital with respiratory infections in preschool children. And so so I should say that we have published our protocol in BMJ Open, so if you're interested in the detailed methodology, please do go and have a look at that. So why are we then interested? Why did I think that we should focus on ambient air pollution and housing conditions? Well, I don't think probably I have to convince this audience. So these are just some of the headlines that I found sort of during this year. But we know that despite efforts by central, that could have been perhaps bigger, and local government to reduce ambient air pollution, is clearly not enough. And we are still breaching EU targets for NO2 ambient air pollution, for example. We've been breaching those since 2010. And the COVID pandemic, I think, has really highlighted that, and the lockdown as part of the pandemic response has really highlighted the risk of overcrowding to spreading of infections in the household, but also the type of housing in which people were locked down and the sort of indoor conditions that they had to endure during lockdown. And I think that's really highlighted the poor quality housing generally we have here in the UK. So in England, for example, 20% of houses, so 20% of dwellings do not meet the decent home standards, and the decent home standards is a pretty low bar, in fact, to meet. Now, there have been other studies that have looked at the association, particularly on ambient air pollution and the risk of respiratory infections in children, but they've either been sort of cohort studies, and they haven't really been big enough to look at some more severe end of symptoms that require hospital admissions, which is what parents have told us that they are particularly concerned about. And if they have been large enough to look specifically at hospital admissions for respiratory infections, they've tended to be in areas that have quite low levels of air pollution, so particularly in the northwestern United States or western Canada. And so that's why that's how we motivated it to the funders that we need this money to do the picnic study. And our aim is to determine the contribution of exposures to air pollution and adverse housing conditions during pregnancy, infancy and early childhood to hospital admissions for respiratory tract infections in children less than 5 years old in England and Scotland. And what we will be using national birth cohort data, so that means that we have data for all children born in England and Scotland during a particular time period. And we identify the babies, I shouldn't say identify, but we include babies based on the birth registration data that then have been linked to hospital admission data. And also via the maternity records, babies can be linked to their mother's hospital admissions, which would allow us to take into account, for example, maternal conditions like severe maternal asthma, for example, that might predispose children to being admitted to hospital with respiratory infections. So I should also clarify that with PICNIC, we're particularly interested in looking at chronic exposures, that's exposure to air pollution and adverse housing conditions over months or years, rather than sort of day by day or hour by hour variations in exposure leading to acute outcomes. So this is our conceptual framework, whereby if we look at the admission pathway here, you have a healthy child who then has a risk of becoming infected with the respiratory infection. And then once they become infected, their immune response, there's some impacts that can happen related to their immune response. So as their immune system are able to fight off the infections, and then given that they are infected and they become ill, how severe are then their symptoms? If their symptoms become very severe, then there are some other factors here that can act on the admission risk that finally then leads to the admission for respiratory infection. So we have this sort of pathway on which we think that risk factors, including ambient outer air pollution and housing, can impact on sort of this excessive risk. So we have a number of intrinsic factors here that we can't really affect via policy, for example. And then we have a number of sort of proximal determinants here, including, for example, a number and age of siblings on infection risks. We have a number of factors that impact on the immune response and on symptom severity here. So, for example, underlying conditions or congenital anomalies in children. And then health service factors that impact on sort of actually leading a parent to take their child to hospital. And then, of course, we have outdoor air pollution, which we think primarily act via the immune response and symptoms and acting on symptom severity. And then housing characteristics, which can affect both immune response and symptom severity, but also via overcrowding in particular, and via dampness, infection risk. But at the top of this plot, you'll see we have socioeconomic position, because we think that is sort of overrides everything else, and it's such an important confounder here. So that affects both these sort of more proximal determinants, and it also affects, of course, your exposure to air pollution and housing characteristics. And the reason why I'm showing you our conceptual framework is that I just really want to highlight how important it will be to take into account socioeconomic position, because we know that those effects are going to be very, very big versus, for example, some environmental effects. So we do need to allow for socioeconomic position in our project. So now we come to the data. So I spend a lot of my time trying to acquire data for Picnic and making sure that we maintain the data as well that we have. So for Picnic, I said we were going to use national birth cohorts from both England and Scotland. And so the spine of that cohort are birth registrations. So all births have to be registered in this country when a baby's born. So we have birth registration data that have been linked to birth notification data and maternity records for all children born in Scotland between 1997 and 2020, and all babies born in England between 2005 and 2014. And then on the left here, we have the exposure data. So we have small area level data or at dwelling level from energy performance certificates, which I'll talk a bit more about later. I'll talk more about these data sources in detail later. We have postcode level data, the national air pollution on air pollution from DEFRA. That's the national air pollution source of data that we have. It's a model annually, a 1 by 1 kilometre grid across the United Kingdom or the British Isles. And then we have output area level data because on tobacco expenditure, because in England we don't have individual level data on smoking exposure during pregnancy or during early life. So we have instead output area level data on tobacco expenditure. And then they will be linked via address histories that are held, so they're NHS address histories. So once you go to your GP and you change your address, that address record will be updated. So in England, that's called the Personal Demographic Service, and in Scotland, it's called the Community Health Index database. So we will actually have these exposures data that are linked to address history. So every time a mother or a child moves, or both usually, we will be able to update their exposure data according to the NHS, to their address within the NHS address history database. And that's completely unique. I don't think anyone else has been able to do that, but we have approvals to do that now. And then on the right here, we have the health data. So we have hospital and mortality records for mothers and babies. So those records go back much further in Scotland than they do in England. And in Scotland has an absolutely fantastic health data linkage infrastructure. So they have vaccination records. So these are all the data we're going to have in Scotland, but not in England. But in Scotland, we'll be able to have infant vaccination records, child health surveillance data. So that's data collected by health visitors, which is information on, for example, tobacco exposure in the home after birth. We have information on dispensed antibiotics and inhalers. We have information from the shielded patient list. So that's people who've been named by their clinicians to be clinically extremely vulnerable during the pandemic. And we also have public health laboratory surveillance data on positive isolates of specific viruses, including SARS-CoV-2, but also influenza, respiratory syncytial virus. So Scotland, we have amazing health data. And then we will, because the DEFRA ambient air pollution data is the 1 by 1 kilometre data, and the annual data is pretty big for a sort of spatiotemporal resolution for air pollution data. We also have model daily air pollution data for Greater London and the City of Glasgow. Again, they will be longitudinal. And so we have a sub-cohort 1 here, a very detailed air pollution, or very fine spatiotemporal resolved air pollution data for a number of children born in Scotland and Greater London. And we also have linked, or we're going to link to census records. So in Scotland, it will be the 2001 and the 2011 census, and in England, it will be the 2011 census only. And that's to get data on the number of people in the household, but also more detailed data on socioeconomic status. So we also have a sub-cohort here of children who are linked to census by the mother census record. But the main analysis cohort consists of data for nearly 8 million children. And I should say that the data are all pseudonymized, so we don't have any identifiers like NHS numbers or names or full addresses available to us for the picnic study. So in terms of the air pollution data sources, so the DEFRA data, we have the data for a number of air pollutants, but we're going to focus on PM10, PM2.5, NO2, and ozone. So they are modeled at a 1 by 1 kilometre grid annually, and we have that for a number of years. And they're going to be linked to the postcode, where the longitudinal, which we will have longitudinally for mothers during pregnancy and then children. And then we have data from Cambridge Environmental Research Consultants from the ADMS Urban model for 4 pollutants, and they are modelled at 100 by 100 metre grid in London and 50 by 50 metre grid in Glasgow for these years. And again, they will be linked to a postcode. So these are the energy performance certificate data, will be our primary data on housing, even though we will also have data on housing from the census. So you might already know about these, but this is what they sort of look like. But you get these energy performance certificates. The data for those are collected by a surveyor whenever a property is let, sold or constructed in the UK, and they're valid for 10 years. And within Picnic, we will use both, I should say, the EPC data at dwelling level are now openly available, so you can download them off the internet for both England and Scotland. They weren't actually when we started this, but they are now. So we have within the EPC data, there are a number of directly observed variables that we will use. So like property type, the number of rooms, the number of heated rooms, total floor area, main gas connection, which is an indicator of indoor air pollution. We have a number of inferred variables that are calculated directly from the observed EPC data. And then our colleagues, our colleague John Taylor, who's now based in Finland, who used to be based at the BART at the UCL, he has modelled the indoor and outdoor ratio of air pollution for PM2.5 and NO2. So we'll be using that as well as an indicator of sort of infiltration of outdoor air pollution. And in England, we'll be able to use data, EPC data at postcode level, but in Scotland, we'll be able to link it to the health data at dwelling level via the unique property reference number. So in England, the only sort of, we have requested to link the EPC data to the health data at dwelling level, but that was rejected, unfortunately. It was seen as too complicated, but in Scotland, we'll be able to link it at dwelling level. So in England, it's postcode level. And as I mentioned, a key thing we need to adjust for here is socioeconomic status, because that will have probably, as I'll show you later, very strong effect on health, whereas we expect smaller effects of the environmental variables. So we have a number of indicators of socioeconomic position within the linked data we'll be using for Picnic. So on the birth certificate, there is information about the parent's occupation. We also link to the postcode. We will have small area level index of deprivation, which I'm sure many of you have used. And also by linking to the census, we will have information on employment and also things like access to a car. That is interesting in itself when we're talking about environmental exposures, but that's been found to be very strongly linked to health outcomes as an indicator of socioeconomic deprivation. We'll have housing tenure, both from census and from the EPC, and we'll also have education level from the census. So we think that we will have an extremely rich set of both small area level and individual level indicators of socioeconomic position in Picnic. And why isn't it moving now? Okay, there we go. So in order to develop the Picnic study, myself, I've done a lot of public, private and charity engagement, because I thought it was a really key factor here to have support from parents and young people. So going way back when, we consulted with parents in Bradford. We talked to them about the prevention of respiratory infections in children. We work closely with the Parents and Carers Advisory Group at Great Ormond Street Hospital. I've been talking to Shelter, and I've been up to visit a coffee morning at Shelter Birmingham to talk to parents who've had issues with their housing. We've talked to the National Children's Bureau Parents Research Advisory Group, and I've also spoken a lot to the British Lung Foundation, the Clean Air Parents Networks, and also more recently the Mums for Lungs as well. So we feel like we have the support of parents and charities, and parents really feel that this is a really key problem, and they're very supportive of the methodology of using linked data. So in order to link all these data sets, we've had to go to a total of 9 committees. So NHS Research Ethics and the Confidentiality Advisory Group is, we don't have consent to link all these data. As you can imagine, getting consent for 8 million children and their parents would be very, very difficult. And in fact, this process has now taken me, we're nearly there, we nearly have the final approval from the last committee. It's taken me 4.5 years now since I first started. And in fact, it's taken so long that one of the committees you had to go to get approval for has actually shut down. So it's been a long slog, but I think we are nearly there now. And I think it will definitely be worth it. And I think we've shown that getting approval for these large-scale projects, integrating environmental data and health data at small levels, you know, because the energy performance certificate data will be linked to a dwelling level in Scotland. That is possible, and ethically, there's an ethical case for doing it. So just very briefly, also to say that when we started Picnic, the pandemic hit, and because we were able to get all these data sets linked, particularly in Scotland, we were able to link to the public health surveillance testing data. We are now running a sort of sub-study looking at the epidemiology of SARS-CoV-2 infection and hospital admissions in children in Scotland. So we're looking at a number of, it's really a population-based study. We're not just looking at children who've been admitted to hospital, but we're looking at risks of having a test, of being infected, given that testing positive, given that you've had a test, and then your risks of admission, multi-system inflammatory syndrome, which is a sort of rare side effects or a rare syndrome that would happen several weeks after SARS-CoV-2 infection, which primarily tends to affect older children, is also called PIMS-TS. And then we're also looking at the risk of intensive care unit stay. And we're looking at this in children and young people up to the age of 23. And we're looking at then how risks of these outcomes vary according to clinical factors, family and socioeconomic, socio-demographic risk factors. And once the environmental data is in the process of being linked in Scotland, and once they are linked, we will be able to also look at the risk of, for example, air pollution exposure and exposure to adverse housing conditions on the risk of being infected with SARS-CoV-2, for example, or being admitted to hospital with respiratory syncytial virus. So we'll be actually looking at be able to differentiate these effects, environmental effects on specific viruses, which will be very, very exciting and novel as well. So as I said, we have pretty much all approvals in place now. We have all the air pollution data, and they are now mapped to postcodes. The energy performance certificate data for England has been mapped and is uploaded to the ONS Secure Research Service, which is where all the data are held. It's a secure, a trusted research environment. My colleague Aimee Lievich at London School of Hygiene and Tropical Medicine is comparing exposure data. So she's comparing the DEFRA data with the data from the ADMS urban model. So it's more sort of coarser spatiotemporal resolution and very refined spatiotemporal resolution, and looking at how we would assess the how different the exposure measurements would look like in by trimester in pregnant women, depending on which air pollution exposure data that we use. We are cleaning and validating the English and Scottish birth cohorts, and then, as I said, the study of SARS-CoV-2 risks in children in Scotland is nearly finished, so we're in the writing up stage. And then I just wanted to show you a study that we've been running alongside of Picnic with some of the Picnic people, including myself, which I think really highlights why we really need national data to be able to look at these effects when we are expecting small effects of environmental exposures compared to, for example, the effect of socioeconomic status or ethnicity. But of course, the environmental exposures are so important because they affect everyone, or a large proportion of the population, and in the example of housing exposures, so that you end up with very large population attributable fractions. So I will just tell you about a study where we looked at child, family, and environmental factors associated with amoxicillin prescribing in primary care in young children in Bradford in England. So, as you know, antimicrobial resistance is still a public health emergency that is not going away. And this is why we wanted to do this study. So inappropriate antibiotic prescribing is a major contributor to antimicrobial resistance. And we therefore wanted to look at how antibiotics, how and why antibiotics are prescribed in primary care to children. So in the UK, the majority of antibiotics that are prescribed to humans are prescribed in primary care, and antibiotic prescribing is hugely common in children. So 1/3 of children aged less than 5 years are prescribed at least one antibiotic annually. And 75% of antibiotics prescribed to children in primary care in the UK are for respiratory tract infections like pneumonia, tonsillitis, or sinusitis. So there has been a lot of research into antibiotic prescribing in primary care, but they have primarily focused on adults. And they've also tended to use electronic primary care records, which I've used a lot, and they're great, but they lack important information. They lack information on important risk factors, including environmental risk factors. So in this study, we wanted to look specifically at amoxicillin prescribing. So amoxicillin accounts for about 60% of all antibiotics prescribed in primary care in the UK, and it tends to be prescribed for things like community-acquired pneumonia, or double-sided otitis media and others. So for this study, we didn't use the Picnic data set, but we used a brilliant data set called Born in Bradford. And Born in Bradford, which you might have heard of, is a cohort study of about 13,000 children who were born in Bradford in England. And then mothers were recruited during pregnancy at the Bradford Royal Infirmary between 2007 and 10. And the follow-up of these children is primarily via linkage to routinely collected health and education data. And we specifically use data from the allergy and infection sub-study of Born in Bradford, which is called All In. And that was a study where the parents who participated in the main Born in Bradford cohort study, when the children were 11 months old, and were invited to participate in All In. And as the name suggests, All In is focused on looking at risk factors for allergy and infections in young children. So parents, if they participated in All In, they were given questionnaires to complete at 12 and 24, when their children were aged 12 and 24 months. So there's around 2,500 children in All In, and there's brilliant data that are linked between maternity records. And there's the baseline questionnaire that parents, mothers, and sometimes partners as well completed during pregnancy. There's a congenital anomaly register. There are the parental questionnaires on very, very detailed questions about risk factors for allergies and infections. We have a linkage to electronic primary care records. And then we also used this DEFRA modelled air pollution data, which were linked, so they're 1 by 1 kilometre grid, annual data linked to the child lower super output area at birth and at 1 year of age via the LSOA. So we had a number of exposure variables in the study, so related to the individual child. So for example, their sex, when they were born, during the year, mode of delivery, congenital anomalies, prematurity status, so whether they were born before 37 weeks of pregnancy. So really, really important risk factors for respiratory infections and antibiotic prescribing. We had data from the mother, sort of about the mother and the family, so their socioeconomic status, maternal smoking during pregnancy, their family use of formal childcare, whether the mother breastfed the baby, and there's also lots of data on the environment. So in the house, then is various indicators of overcrowding, visible mold or damp, gas cooking, or then we had this quartile of PM 2.5 exposure. So, and we related that to the Bradford annual average levels of PM 2.5 to make it more easy to interpret, I would say. So, and then we looked at 3 outcome variables. They were 1 or more amoxicillin prescriptions, 1 or more consultations for lower respiratory infections, and 1 or more consultations for upper respiratory infections. So these are some of the results from that study. And for amoxicillin, the rates were high. So at age 1, the rate of amoxicillin prescribing was 710 per thousand, and in age 2 it was 780 per thousand child years. It's very high. This shows you mutually adjusted odds ratios for ethnicity and socioeconomic position, and we fitted the models by year of age. So this is the first year and the second year of life. And you can see that if your mother is Pakistani and born in the UK, or Pakistani or not born in the UK, you had the child had higher risk for amoxicillin prescribing, and that's the same in the first and the second year. And also for socioeconomic status, you can see that there was a 36% increase in odds in the most deprived versus the least deprived during the first year of life. But then if we look at the environmental variables, I should say here also that we only included variable in the models when they significantly improved the fit of the model. So for the vast majority of environmental variables, they didn't improve the model fit, so we didn't even include them. So we found no association essentially between, for example, gas cooking and amoxicillin prescribing. However, we did find no association with mold or damp or a PM 2.5 here in any year. If it's empty, it means that the model this inclusion of this variable didn't improve the model fit, which means no association really. But we found that overcrowding increased the risk of amoxicillin prescribing during the first year of life. And similarly for lower respiratory infections, I'll show you the results for amoxicillin and lower respiratory infections. You can see that ethnicity, particularly for the second year of life, but also socioeconomic position, seem to be associated with low respiratory infection consultations in primary care. And again, we found we didn't find any association with any environmental variables here. So what we found essentially was that 43% and 47% of children respectively were prescribed amoxicillin in their first and second year of life. And ethnic group was consistently associated with amoxicillin prescribing, in that children whose mothers were Pakistani had higher risk compared to white children being prescribed amoxicillin, and also with lower respiratory infection consultations. We found that socioeconomic status associated with lower respiratory infection consultations and also with amoxicillin prescriptions during the first year. And the only environmental variable that was associated with amoxicillin prescriptions was overcrowding. And I think this shows what I was trying to say before, is that we're looking for smaller effects of environmental variables, but potentially large population attributable fractions. But factors such as socioeconomic status or ethnic group are always going to have a bigger impact on the sort of outcomes that we're talking about here. The data in Bourne and Bradford is amazing, but it is limited to Bradford, which is which is one area, one city. It's a big city, but it's one city in England, and it has a very particular ethnic group composition. Sort of half the mothers born in Bradford are white British, and about half are Pakistani. So it's a very specific ethnic group composition, which is not the same across England. And so we need national studies here. I think that's what this study demonstrates, that we need national studies where we have greater variation in environmental exposures across different families with different backgrounds, ethnic backgrounds, socioeconomic backgrounds, in order to detect these quite small effects, but effects that are very important because they affect us all, if not a very, very large portion of us. So in terms of what we learned from the picnic study so far, is that I think we do need large national administrative data set linked to environmental data to examine questions of the impact of ambient air pollution and housing on child health. And the reason we need these type of data is that they are inclusive, they are large, and they cover a large geographical area, so you get variation in exposure. But these linked data sets are very, very difficult to access, and so it took 9 applications over 4.5 years to multiple data providers to get access and to get these data linked and to get us to access them for research purposes. And this is despite a low risk of disclosure, because they are held in trusted research environments. The data are held in trusted research environments, and we have evidence of public support. So I just want to thank all our project partners for Picnic, and also the people who worked on the amoxicillin study of all in, particularly Faith Miller, who's a PhD student at UCL who led that study. And thank you very much for listening to me. Can I stop sharing my screen now, because I can't see anyone?
Thank you very much, Pia. Yeah, by all means, stop sharing your screen. And thank you. Very interesting, and obviously huge challenges with this large data set. We have a few questions related to that. But before we get on to that, a couple of sort of broader questions. I think one which struck me as well from Sophie, who says, at the top level, how do you separate out the impact of air pollution from bigger confounding factors, such as socioeconomic status?
So so first of all, we do it using these big data sets that are national, because we are then able to compare areas that have similar levels of deprivation. For example, Cornwall and some parts of inner London, there are very, very poor parts of Cornwall and very, very poor parts of inner London, but inner London will have much higher risk of air pollution, for example, high rates of air pollution exposure than in Cornwall. So I think that's really why we wanted to take this national view, because within London there's such strong links between socioeconomic status and air pollution that I thought using the sort of national data would help us get around that. But it is going to be tricky. Essentially we're using statistical modelling to try and adjust for socioeconomic status, but I think the key to it is using the national data, where you're able to compare similarly deprived areas in different parts of the country.
No.
But I don't have a simple answer. We're going to have to play around with various methods to do it.
Thank you. And I guess related to that, Hugh Woodward's asked the question, what are your plans for the higher resolution data that you have from CERC in London and Glasgow? Will you look at the impact of potential impact of acute exposure events, or what?
Well, we were particularly interested in those to try and first of all, so for some pollutants like NO2, we know that they vary much more over smaller distances. It will be particularly important to look at the effects of NO2. I think the other thing is that we wanted to be able to look quite finely at effects during pregnancy, and then, you know, to be able to, and this is what my colleague is looking at now, is to sort of compare, if we use the sort of finer temporal resolution data, is that going to give us very, very different exposure levels compared to using the DEFRA data? So we're particularly going to use that to look at exposures during pregnancy. It would be really interesting to look at the impact of short-term exposures as well, but our focus, so if we have time, which we might do, we can look at those effects as well, but we're primarily sort of looking at the chronic effects. Yeah.
Okay, thank you. And I guess related to that, or related to the first question, was from Tom Sturgeon. He asked the question, within the Born in Bradford data, are you able to look at intersocioeconomic and ethnic correlations independently? And he means correlations to the prescribing data.
So do you mean, so independent, so we did include both variables in the model, so technically they're mutually adjusted for. However, what I should say is that they're clearly very, very strongly linked, and the ethnic group in the Born in Bradford cohort is also very, very strongly linked to other really important exposures, particularly maternal smoking. So I think something like 3% of the Pakistani women smoke during pregnancy versus 30% of the white British women. So there are, so we can sort of put these variables in a model, but really we can't, because they're so strongly linked. It's hard to really separate them out in Born in Bradford in particular. So yeah, it's difficult. We also haven't looked at, so I'm not quite sure exactly, but we didn't look at any sort of effect modification of socioeconomic status on ethnic group or vice versa. For example, we didn't feel that there was enough statistical power to do that. But that is something that we are looking at for PICNIC potentially. Yeah.
Right. Yeah. And Tom Sturgeon has a second question, which is about using NHS address data. And he said that he believes there have been issues using this in COVID, particularly for London, where many people's NHS registers addresses are not where they actually live. And
it's a real key point.
Okay. Yeah, he says, I suppose the question is, to what extent have you interrogated the risks, uncertainties around using that data in the analysis?
So I know it's so basically what happens is when you report to any sort of part of the NHS, usually your GP, I think, but technically also hospital, and they say, is this your address? And you say yes, that's fine. And if it's not, then you check it. So it is very much censored according to when you see your GP. And we know that for particular groups like younger people, students, younger men who don't see their GP very often, those records aren't going to be terribly correct, which we did see during COVID. However, I think in this group of pregnant women, of women with young children, I think it would be better because they need to go and see their GP a lot. So I'm hoping that it is difficult because it's the sort of the gold standard really, and it's what the ONS, for example, have used to look at internal migration. But we're definitely aware of this. And I think it will be better in the group we're talking about, but I am definitely aware of the problem.
Right. Thank you. I don't think there are any more questions in the chat. I have a question of my own, which is, from my experience a long time ago, bringing up young children, and every time they went to nursery or back to school, the whole household got sick. And it does seem that, within households, infections spread some things spread quite vigorously. I mean, I wonder whether, looking at that and looking at COVID in particular, whether you can make some assessment of how important is inter-household or within a household infection rates compared to, across the wider community?
Yeah, there have been a lot of studies looking at that for COVID in particular, for example, spread at school. So in relation to children spread at school versus within the household, like you're right, the household seems to be key for SARS-CoV-2 spread, definitely. So I think the main indicator we will have for that is either parity, so the number of older siblings that we have, or the number of people in the household, which we would have from the census. So those are sort of the key data we have. It's a bit difficult to look specifically at household spread here because the health data is based on healthcare contacts. So in England, for example, we only have hospital admissions, and it would be quite rare that 2 kids would be admitted. So it's hard.
Okay.
I completely see what you mean. I think the level of granularity of the data isn't good enough here, but we do have some indicators of sort of the size and the amount of crowding in the household.
Right.
Just in relation to schools, I just wanted to say, of course, that we're focusing in Picnic on preschool children because these exposures have effects already during pregnancy, and that's why I wanted to start there. But of course, these children are going to grow up, and some of these children are going to develop more severe respiratory problems like wheeze or asthma that are chronic. And I have colleagues who have been linking the hospital episode statistics data, which is the English hospital data, to the National Pupil Database. And so applying for grants now to try and extend the linkage to National Pupil Database data. So you will be able to look at sort of the long-term effects of these type of exposures on school outcomes, but also be able to look at the effect of exposures at school on health outcomes. So hopefully that will come through, but who knows? But so I realised that the TAPAS network is focused on school exposures and I mainly work on preschool children, but we are definitely hoping to extend this to look at schools data as well.
And I think developing the methodology and testing it, of course, will be a big asset because we can hopefully take those kind of methodologies that you develop into other contexts and so on. Yeah. Okay. I've got another question here now from Holly Wader. What do you hope for Picnic's impact, for example, on policies about housing?
Obviously it depends on the results, of course, but the whole aim of this will be to try and I have another role as the lead for administrative data analysis as part of the Children's Policy Research Unit, which is a large NIHR funded program where we work very closely with Department of Health. And so we have frequent meetings with the Department of Health. And I've also talked to, for example, Ministry for Housing, Communities and Local Government. And so I am it's difficult to, obviously, I really hope we'll do everything we can to see that our evidence-based results, our evidence-based findings have impact. But in my experience, it can be quite difficult. But we are obviously trying through sort of all means and also working with charities, I think, to try and empower parents themselves to sort of use evidence and impact local change, perhaps in particular, will be brilliant. So we are working on that as well.
Okay, thank you very much, Pia. That's been a fascinating talk, and I think I realise that Picnic is still has a way to go. So we look forward to perhaps having a revisit in some time to hear more of the results. But it's a really interesting project, and obviously we're through TAPAS very concerned with children, and as you rightly say, these little ones will soon be in school. So it's a nice connection. Just to say to everyone, of course, that as you all know, I hope TAPAS is a network. We have a range of activities and newsletter. If you don't receive our newsletter, please get in touch with Sophie Bristow, who is the network coordinator. The next seminar will be next Thursday at the same time, 1 o'clock. And that's by our very own Sarah West from the University of York. And she's the director of the Stockholm Environment Institute, and Heather Price from Stirling University, talking on citizen science approaches to engaging school communities in air pollution research. And Sophie has very kindly put the contact information for her and the network in the chat. So with that, I'd just like to thank you all for attending, and thank you again, Pia, for a fascinating talk and an explanation of your work, and look forward to seeing you all again in a week's time. So thank you very much, and bye-bye.